Good morning, everybody, and welcome to today's presentation. Our speaker today is Dr. Emmanuel Taban. He is a pulmonologist, a very well-respected pulmonologist, and a specialist or expert in critical care. He has a passion for education, and that's really where this platform came from and why he decided to start this. He is a teacher and a mentor to many doctors on a daily basis, including myself. He originally came to South Africa from South Sudan on foot, and since then he is pursuing a lifelong journey of self-improvement and seeking a higher purpose. He has recently returned from a trip abroad where he had the privilege of learning many new techniques, procedures, and treatments in managing the latest management of chronic obstructive pulmonary disease, which is where his heart lies. So today we're very fortunate to have him present this topic, cough.
Thank you, Leanne. Impressive that you don't even have the slides. Very impressed. So my topic today, I'm going to be discussing about cough. Every day, we all wake up, we clear our throats, we cough, and we actually sometimes cough become the single most important things that sometimes give us anxiety, push us to go see a doctor, seek attention, and because cough really kind of, it brings kind of certain kind of connotations. One is, of course, being cough. People around you sometimes feel that you have a very serious disease, and in that case, most of the time it's COVID. Everybody cough and everybody just walk away from you. And in other people, especially women, when they cough, sometimes you lose your bladder control, and as a result, you end peeing for yourself, and that's really very embarrassing. Or of course, the fact that people get discriminated because of the amount of cough that they have. So people really seek cough medical attention because of cough. And most of the time, most of the problems are not really addressed. So I thought perhaps today let's have a discussion about what's really cough and how do you actually address it and the types of the cough and which coughs really is the most important that push you to go and seek for medical attention. So we'll start our discussion, of course, with two things. We're going to be looking at a definition of cough, which is very important. So cough is really an explosive expiration that protects the lungs against aspirations and also promote the movement of secretions and other airways constitute towards toward the mouth. Cough may be voluntary, of course, or involuntarily, or combination of the two if subjects attempt to control an involuntary cough. So involuntary cough is stimulated by mechanical, inflammatory, and psychogenic. Cough is one of the most frequent causes of visit to the doctor's office. When said voluntary, cough means you induce a cough yourself, you have control over it, while involuntary means you have no control over it. So definition of cough, of course, is defined by the duration of cough, and that's really, I think, is very important. So we can define cough into three categories: acute cough, which is present for less than 3 weeks, and subacute cough present for more than 3 to 8 weeks, while chronic cough present for more than 8 weeks. And this is the reason why we divide it that way, because that can link to the cause of cough. And if you look at the diagram, it's really looking at the pathophysiology of cough and how do actually somebody start coughing. If you look here, the cough, of course, you look at the center where the cough is actually, a cough receptor is located. So the center of cough is located in the central nervous system and the cortical modulations, which is you have your cough center, and it's in medulla. It's next to the nucleus tractus solitarius. Okay. So now, how did the cough get stimulated? Of course, you have receptors in the body that transmit information to the brain, and then those that bring information back to the muscles so that you can have a cough. Okay. So the locations of those cough receptors, of course, would be at the larynx and superior laryngeal area, means that is in your mouth. And then ear canal, of course, the ear canal and eardrums is very, very important. And then pleural and pericardium and diaphragm, also very important. Esophagus and stomach is very important. Why do we say that? Because sometimes you go to a doctor and because you're coughing, then the doctor and listen to your lungs. And then because your lungs aren't clear, then they say, no, you get cough syrup. But when you actually present to your doctor with cough, you need the doctor to look at those 5 areas. They need to look at the ear. Because if your ear, you got what's in the ear, you're going to have a chronic cough. They need to look into your nose. If your nose is blocked or you got septal deviation, those mucus can drop into your larynx and you cough. And they also need to look, obviously, at the bronchial tree, which is most of the time the cause will be things like asthma and other things in your lungs. But also, patients that are really probably having a BMI of more than 25, means overweight, 25 to 30 is overweight, or BMI of more than 31, again, that means they're obese. Those patients will have a silent reflux and they will have chronic cough. But what's so important about the cough, they tend to cough while they're lying supine position. And once any of these centers, whether it's wax, whether it's the larynx or trachea, their nerves get irritated by any of the stimulus, then of course the nerve innervation of this area is really vagus nerve. So the impulses are transmitted by vagus nerve to the cough center in medulla, nucleus tractus solitarius, and then from there the output is sent back by 3 nerves. The spinal motor nerves, which is really what it does. The effect will be, of course, that it stimulates your expiratory muscles, include pelvic sphincters. And that explains the reason why when people cough, they tend to pee also sometimes. They have urine leak. And that's because of the coordination of the spinal nerve. Okay, so it's something that means people don't need to worry. Their blood is not a problem. It means the cough needs to be addressed normally by physicians, and then after physician, pulmonologist. Phrenic nerve that innervates your diaphragm, and that's very important if you're having diaphragmatic palsy or you're actually having reflux. And then the last is vagus nerve that innervates your larynx, your trachea, and bronchial tree. Also, that's how people respond. So let's look into acute cough. As we say, acute cough, maximum duration is less than 3 weeks. And the commonest cause is really what we call upper respiratory tract infection. That most common is tend to be viral and tend to be limited. And the most common, of course, will be rhinovirus, RSV, and others, most common. And then, of course, we talk about bacterial bronchitis or tracheal bronchitis, which is also another one, means the infection of your tracheal bronchial tree. And of course, aspiration is one of them, when your acid or food just go to the wrong hole. Pulmonary embolisms, which very unusual presentation, but also can give you cough. Pulmonary edema in the context of the heart failure, and early manifestation of chronic cough, of course. There's no way of predicting duration of persistent of cough. Nobody can predict that the cough will last 2, 3, 4 days. But how you predict it, it depends on what caused the cough, especially. And benign, of course, neglect is usually the best approach. So most of the people with mild cough, you just ignore them. But if persists, they need to be investigated. And at the beginning, of course, acute cough, avoiding imaging, if no focal finding or persist fever. If somebody just cough or something like, avoid CT scan, in that context. And then this is our flow diagram of acute cough, of course. Acute cough, if you have acute cough, we look at one of the key, of course, we look at is it a life-threatening or is it just a non-life-threatening diagnosis? And the most important life-threatening diagnosis, we're more concerned about if you're having pneumonia, you're having severe exacerbation of COPD or interstitial lung disease, of course, and someone with pulmonary embolism or right heart failure. These are very severe, and those patients probably need to be referred to a specialist, and further workup need to be done. Okay, and then of course non-threatening conditions, and those will be things that really you look at that exacerbation pre-existing conditions. So these are really non-threatening, means these are patients that are having existing problems also. Those will be things like asthma, and means if they haven't used their inhalers or they're having new infection on board, patient with underlying bronchiectasis, what we call upper airway cough syndrome, of course, COPD and others. Okay, and then I mean you look at and then obviously you look at other things that kind of like fever, weight loss, and all those, So you look at all those signs that can assist you to see actually how do you want to approach that cough and how do you want to address it? Urgently, refer, or treat it at the practice. So what is the therapy for acute cough? Of course, we normally use quite a few things. First generation antihistamines, or also you can use also the long-acting decongestants such as bromophenil, bramines, or pseudoephedrine. Can be helpful, but the mindful this sometimes can give you tachycardia, and people have a different kind of side effect. We cautious about allergies. And of course, there's a new generation antihistamine that are not really so useful in cough. And then, of course, inhale ifotropamine may be helpful. But again, that does not mean you have an asthma. And then also inhale albuterol, means most people would resort to nebulization, especially when they have an underlying wheezing in their chest. And then you also, if you, as a caution, you must avoid the oral counter medications. You must stop them, especially in children. And this is really tell you about what are the different cough medications available in the market. And you can see when you go to pharmacy, you have those the antitussive, those with underlying codeine, or also those with the dexamethasone, and obviously as a ACC, which is quite very common in the country. And subacute cough, or what we call post-infective cough, this is a cough really that starts 3 weeks after acute cough, but it lasts for less than 8 weeks. And again, if you look at the flow diagram, which I'm not going to go through it, you follow through approaches, and most of them really effective in nature. So acute cough, subacute cough, of course, you look at as I said, the duration 3 to 8 weeks, and the commonest studies that are found is having bronchitis, pertussis may play a significant role. Without a significant comorbidity, symptom relief is probably the key step. Evidence supporting use of codeine not convincing. So again, people normally tend to go to codeine-based kind of syndrome. Sorry, adjacent to access people need to allow to come in. Yeah. And then the peripheral cough suppressor may be also helpful. Okay, so testing for pertussis is best reserved for epidemiological purpose because that's not assist us about vaccination status or infection. Because if you're worried about whooping cough, normally you need to treat an acute phase. But if it persists for more than 6 weeks or more, treatment does not add value. So treatment of B. pertussis include macrolides of course, that will be azithromycin and also Bactrim within 1 to 2 weeks of symptom onset. So again, in chronic, we say 3 to 8 weeks, means sometimes the benefit's not going to be there. Quickly touching of the hepatitis, of course, clinical criteria. In the absence of more likely diagnosed, a cough illness lasting for more than 2 weeks with at least one of the following signs or symptoms. When the patient have paroxysmal of coughing or inspiratory whoop or post-tussing vomiting or apnea. And this is more likely one of them. So you know that sometimes patients have it. Laboratory criteria, when you have isolation of the B. hepatitis from a clinical specimen or positive PCR test confirming the diagnosis. And this is really the option that you have for treatment. It's a small slides, but really self-explanatory. So there's quite a few studies. In one study, of course, where there are 184 patients with subacute cough, nearly half of the patients had post-infective cough that resolved within specific therapy. And this was a study really done in, was a UK-based study and was published in CHEST in 2006. In separate study of 41 patients with the subacute post-infective cough, the cause was found in 12%, and this is a Japanese-based study. So the most important really which I want to talk about is more the chronic cough. Okay, chronic cough by definition lasts for more than 2 months. Only 3 studies utilize the 8-week cut-off durations, reporting the prevalence of at least 12% in UK, 2.2% in Japan, and 1.1% in Nigeria, respectively. Cough for more than 3 months, which is also, again, for in the past, if you look at the definition of COPD, they define chronic bronchitis as a cough for more than 3 months or 3 consecutive months or more duration during the year. And that prevalence, if you use the definition, so-called the prevalence of chronic cough dropped to about 7.9%. So natural cough and dry cough were more prevalent in women than in men. The reason why, probably there's underlying components of underlying anxiety, but also maybe probably neurophysiology, part of it. And quickly, I think I'll explain this diagram later again, or as one of the causes of pathophysiological cough. But the most important to look at the common cause of the chronic cough, okay? So the cardiac symptoms, of course, will be the most important duration, more than 8 weeks. And of course, the patient will have a starter or trigger. And current, of course, then you need to find what's the current trigger, and then sputum obviously is important, the color sputum. The other symptoms, of course, will be your dyspnea, on exhaustions, pain, chest pain, and sometimes they'll have sore throats, headaches, and reflux symptoms if you think that it's underlying GERD. And the most importantly, again, you look at the relations to the hypersensitivity to fragrance, like perfumes, cold, that will point you toward asthma, voice change, that will tell you that maybe the underlying laryngitis, cough while eating or drinking, lying down, then that will tell you that either it's aspirations or vocal cord dysfunctions. Then present pulse illness in patients that are looking for coughs. So I think it's very important to understand the previous infections where they have underlying pseudomonas or TB, which probably those patients have scar in the lungs, so underlying bronchiectasis. And then, of course, chronic disease, such as bronchitis, COPD, asthma, if they were diagnosed before, or if they're having underlying history of smoking or occupational disease or previous family history of asthma. It's very important to look at that. Allergies is also very important, and also gastroesophageal reflux disease. But of note, again, patients with the gastric reflux, most of the time they can be asymptomatic, especially when they are been having chronic problem for a number of years. And most of these people tend to be really above the age of 40, 50 days. But again, it's not a rule. Young people can also have issues with the refluxes. And obviously, it's important to think about obvious heart diseases. Mostly, you have to look at the features of left ventricular dysfunctions, or with the fetal edema, things like autopnea, PND, all of them play big roles. Okay, and then status also post-surgical with intubations. Okay, patients that have been in ventilation for a long time, they can develop tracheal stenosis. It's often very important to consider all those aspects. And then pre-existing neurological conditions, aspiration. Again, one of the biggest cough symptoms that are seen in our context would be the women coming out of chronic cough, and most of them really due to the dysfunctional breathing because they tend to hyperventilate. But again, it's not specific, but I think sometimes it's worth considering. Exposures, you must look at exposures, would be things like smoking of tobacco, or nowadays the new kid on the block, vaping or e-cigarettes playing key roles. Occupational toxins, of course, that will be people that are probably staying from Malanga area, Middleburg, and Secunda area, or Sasolburg, where the air is quite very unclean. And obviously occupational, and then you're looking at about animal contact, those who are probably having parrots at home, or exposed to pigeons, they can develop hypersensitive pneumonitis. And of course, the other things, of course, and then drugs can trigger cough, such as acid inhibitors, those that take acid inhibitors for high blood pressure, like Prixium, Prinda, or what they call them, carbapenems, they can have chronic cough. And then the last, of course, not least, you have bronchoconstriction symptoms like beta blockers. Again, somebody who got underlying asthma, then they take beta blockers, they can also have cough. And then, of course, we have to consider the risk factors, especially women that are using contraceptions that are having high risk of develop pulmonary embolism, but not every woman, again, it's not a rule of thumb. And then patient with pulmonary toxicity or drugs that actually can damage the lung. Patient-specific factors will be the risk factors for for tuberculosis, patient underlying immune problems living in overcrowded area, those from endemic areas such as South Africa, Sub-Saharan Africa, and India, the risks are quite very high. And of course, we look at psychogenic situation, which we talked about it already, and those called dysfunctional with dysfunctional breathing. Then relevant condition, different diagnosis of chronic cough. The common, of course, we're looking at about chronic obstructive bronchitis, which could be as a result of COPD, chronic viral asthma, and bronchial asthma. These are really common. And extrapulmonary causes will be upper airway, chronic cough syndromes, and gastroesophageal reflux disease. Uncommon would be your things like bronchial or lung cancers, primary and secondary. Of note, can happen in non-smokers too. It's not specifically smokers, non-smokers also can have that. And hepatitis, as we talk about it, and also eosinophilic bronchitis. And extrapulmonary would be drugs, especially AC inhibitors, and then cough of unexplained origin, chronic left heart failure, vocal cord dysfunctions, much more common in women. Rare condition would be infections such as tuberculosis, but that's not very rare in South African context or Sub-Saharan Africa and also India. Opportunistic infections such as PCP or pneumocystic Giardini pneumonia. And of course, you look about tracheal bronchial collapse and bronchiectasis, interstitial lung disease, and cystic fibrosis, and not forget pulmonary fibrosis in patients above age of 85. And those with underlying extrapulmonary malignancies, such as Hodgkin lymphoma, aspergillus diverticular, or those with also metastatic conditions to the lung. Gastroesophageal reflux disease, I would just want to touch about it. It's very important conditions that actually really affect a lot of people. It's a high likelihood that this is the source of idiopathic cough if they have good symptoms. Frequent coexist with other cause of cough, and then role for 24-hour pH manometer is contagious in these patients, and non-acid reflux may be important. Possible role of esophageal dependent studies. Remember, patients should be off reflux therapy before study, and procedures are expensive, so trial of therapy warranted. So if you talk really about patients with the GORD, the problem that, again, as I mentioned before in the opening of my presentation, that they tend to be people with the age BMI, means body mass index, of more than 25, but worse with those with the obesity class 1 to 3, and also those who probably with the, I think, immaturity, preterm births also tend to be quite very high. And people that those doing a lot of weight lifting, also there's increase of GORD, and of course and those probably have failed surgery before. So medication for anti-reflux disease, I always say there are very few things. One is prokinetic, dietary, and lifestyle modification. I think that's very, very important. In my practice, I always tell my patient we have to think about topology, which is like, it's a concept that really comes from township where they're worried about these small evil tree, so they can't put the bricks on the head of the bed to lift the head of the bed up. And that actually helps relieve the acid reflux. And you just need to put one bricks on the just between the floor and the legs of the bed, not on the pillows alone. Does not support. Pillows are not helpful in preventing reflux. So it have to be bricks or lift the head of the bed up with if you have those special medical bed. But those are very expensive. Bricks are cheap, 2.5 rand, or even you can get it for free from your neighbor or something like that. So that already play a massive role in preventing refluxes. And then, of course, then anti-PPIs. PPIs are very good, but we can't use them for long term, because if you use a high dose of PPIs, yes, it takes about 3 months for the symptom to improve. But the problem with the PPIs is that they tend to suppress actually your acid in the stomach, and that increases risk of resistant bacteria in your stomach. And most of these patients will present recurrent pneumonia because they're having this silent reflux aspiration. So it's very important that perhaps the number one is dietary, number two, leave the head of the bed, number three, lose weight if you're overweight. That would probably assist quite a lot. And of course, there's a lot of other additional agents. And then we consider Nissan purification as a last resort because it does not really solve your case. And most of the time, are really against use surgery for anybody above 65. They need to be clearly vented that there's no underlying lung issues because sometimes mortality tends to be very high. And also, again, depends on the centers. Then we have covalent asthma, which is this normally confirmed by methacholine challenge test, suggests for confirmation. Initial cells should be inhaled corticosteroid, and in patients refractory to inhaled corticosteroid and who have been adherent to medication therapy, and then removal of pending irritants or allergens. Okay, a trial of leukotriene receptor antagonist therapy is reasonable, and assessment of airway inflammation can be considered, such as you can use expiry nitric oxide. If co-refractory to IC, trial of 1 to 2 weeks of oral corticosteroids is warranted. And then upper airway cough syndromes, there's no pathognomic findings. They tend to be really due to allergies, infections, or vasomotor etiologies are most common. And empiric therapy trial of therapy for upper airway syndrome warranted in idiopathic cough syndrome. First line therapy include first generation antihistamine or decongestant. Nasal corticosteroids are widely used, but unclear if specific substance of upper airway cough syndrome benefits. And again, most of the nasal spray, they tend to cause nose bleed. So again, maybe you don't use it continuously, intermittently when you need it. And of course, most of these patients, I think if they've been screened for allergies, then you would probably be cautious. If you're going to go, let's say you have got allergy to grass and you're going to grass area, then you can use it. But if you think that you're not in grass area, then you don't need to use it. And also, again, most of them because of pollen, and then you look at the season. So you don't use it throughout the year. You can use it based on the season that you think that your allergy is quite heightened. If there's a history of atopy, non-sedated antihistamines should be substituted. We have quite a lot of them. And consider imaging of sinus if strong suspicion of sinus etiology or no response to trial of empiric therapy. And this imaging, of course, will exclude things like the nasal septum deviations, but also nasal polyps. And the elderly people, there's risk also malignancy. So it's always very important to have a look at that. Time the ENT is warranted to refer the patient to ENT. They might benefit from the nasal sinuses washout or removal of the polyps. But also the strengthening of the symptoms. I've seen a lot of patients that want to eat, and if they don't go to a reputable ENT, sometimes they tend to cause more mess actually than actual benefit for the patient. So it's very important that the patient don't rush for surgery, have trial medication first, and if it doesn't work, have discussion with ENT, look at the benefit, and make sure that you make the right decisions. Non-asthmatic eosinophilic bronchitis, of course, is a eosinophilic airway inflammation without bronchial hyperresponsiveness. On spirometer, chest X-ray will also be typically normal, can exist with other causes of cough, consider occupational-related cause, inhale corticosteroids as first-line therapy, consider oral corticosteroid therapy if no response to inhaled corticosteroid. Respond to inhaled corticosteroid oral corticosteroid alone does not differentiate non-asthmatic eosinophilic bronchitis from asthma. Must demonstrate airway eosinophilia. Induce sputum prepared. Bronchoscopy not routinely warranted in those patients. Angiotensin converting enzyme inhibitor cough. These are patients that are very hypertensive with essential hypertension that normally put an ACE as a first line for whatever reason, because ACE really have greater roles in mortality reduction, cardiovascular, but also in renal. And that's why we really use ACE. But unfortunately, ACE having as one of side effect because of its pathway, there's increased release of bradykinin that induce cough. And can acquire approximately 10% of treated patients. So if you look in South Africa, we have a high number of patients with hypertension. So 10% is quite a huge number. So before patient actually embark to go see a pulmonologist, which could be very costly, they need to call their general practitioner and ask whether they're on ACE inhibitors. And if you have ACE inhibitors, perhaps just stopping that will resolve the cough immediately. Therefore, trial of sensation always warranted. First line therapy in sensation AC, usually resolve 1 to 4 weeks, can replace with ARV, it's angiotensin receptor blockers. And if AC1 cannot be stopped, consider sodium chromogalaket, which is, I think we don't have in South Africa, was people using excess in use asthma. I haven't seen one. I'm trying to get one from US, but I don't think it's prevalent in South Africa. Theophylline also can be used. Indomethacin, provided you don't have aspirin-sensitive asthma. Amlodipine is always indicated. And then your calcium channel blockers, and has variable success. Pop hypersensitivity syndromes, and this is really probably a very difficult one. I always struggled with to find the that to say that this is really where it is. And I think I haven't really diagnosed one, and I'm not so sure whether it exists. I'm still questioning it, but it's something well described in literature that the patient got hypersensitive cough reflex. So can be measured with capsaicin, but or citric acid. Again, not specific. We don't do it in South Africa commonly. May occur independently or with common cause of cough. I mean, now if you're having acid reflux, so it becomes difficult really to differentiate between the two. And it's female predominancy and somewhat older, 66% female, 60 to 90 years age group, most common. So I'm not so sure how to distinguish that actually from dysfunctional breathing, but maybe blood gas will be helpful. And not clear if these are the patients that respond to gabapentin. You will see normally used by neurologists. So trial of gabapentin, 300 milligram daily, or gabapentin increased to maximum of 1,800 a day, limited by side effect or tolerability. Amitriptyline may also work, and dark chocolate has been tried, but results suboptimal. And for women who are in love with chocolate, please go for it, but monitor your weight. And then, of course, this is really the summary management of cough. And really, it's quite, you have your medications, and then you have in treatment modality, the most important physiotherapies for induction in sputum, and those who are underlying conditions such as bronchiectasis, COPD, and of course, physio would be helpful. And then morphine is something I don't want to discuss about it, and the gabapentin, because this is a public platform, I think morphine should be prescribed by specialists. So, just need to touch on the mucus characteristics. I know people are out there that are having cough, and immediately you want to cough, you now start panicking. But it's very important to see what does each mucus actually mean. Okay, so now mucus characteristic, if you're having pink or frothy mucus, for men it's going to be difficult because most men are colorblind. But that indicates that the patient got pulmonary edema, means it's a serious problem. They need to probably seek medical attention through their GP to a specialist as urgent as possible. And if the mucus is corpuscles and proteins, saliva-like, and that normally tell you that there's underlying malignancy. If they're thick mucoid with cast, you're worried about asthma, with especially the allergic bronchopulmonary aspergillosis or plastic bronchitis. And if the malodorous, you're worried about the aspiration with underlying lung abscesses. Yellow or green tend to use infection, except in asthma. In asthma, yellow or green mucus means you have just increase in eosinophilia. And that means somehow it also tells you that you are not been using your inhaled steroid properly, or you're not been on the steroid. Mucus characteristic, because you have the rusty colored mucus that tell you about pneumococcus infections, internal infections, and then brownish or chocolate color. Those are amoebic lung abscesses. And when there are cases, what you call cheese-like tuberculosis, and also the purulent, intermittent, bloody, and also influenced by posture, then worried about bronchiectasis, and most of these people produce for more than 10 mils a day, or 50 mils even. And if the current jelly sputum, you're worried about blood, mucus, debris from infections, classically Klebsiella pneumonia. Other characteristics of the mucus, of course, will be when they're temporal, means early morning. They tend to be more in smokers and chronic bronchitis. If they're nocturnal, they tend to be asthma and pulmonary edema. And if you like 8 o'clock in the evening, you're worried about aspirations. Sound, whooping sound during inspiration, that precede cough, you're worried about hepatitis. Backing sound during cough. And laryngotracheal also infection, viral diphtheria also. And this is really the end of it. And this is the reference are from World Health Organizations and also a few articles. And thank you.
Thank you very much for that presentation. I think it's something we see on a daily basis. And we probably need a reminder of how to actually approach it and to be able to identify the cause.
Yeah, I think it's very important. Cough is just very common that people need to understand it. And I think in context of South Africa, everybody coughs, they get antibiotics. This is very unnecessary. So actually it's very important that they don't just dish out antibiotic for everybody that have cough, because some of them could be viral, some of them would be acid reflux, and it's not really specific for you to treat the patient. I think you must be guided with other things. I always say cough without fever is not equivalent to bacterial infection. So you need to have cough associated with fever, and obviously maybe prevent infective cause, then you could actually treat. Yeah.
Yeah, it's no point going for numerous courses of antibiotic and you're dealing with something else. Is it a problem not to cough?
Well,
because it has a positive. I mean, in the view from the viewpoint from a patient, it's, as you said right at the beginning, it's a very negative thing. People don't want to cough at work. It's irritating, it's interrupting what they're doing. But the other perspective is there because you need to clear whatever, if it is coming from the lung, you want to clear that mucus, you want to bring it out. So, yeah.
I think that's why, if you look at the patient, we talk about that they are on the acute cough, that sometimes it's very important that you ignore it. Because especially when it's 1 or 2 days, you shouldn't be worried about it. And I think cough per se is just a messenger, and you really don't need to shoot it down.
Yes.
And it probably tell you that there's underlying problem that need to be addressed. Where those problems are acute or subacute or chronic, that's when people can seek medical attention. I think at the beginning, 2-3 days, obviously, if associated with the central upper respiratory tract, then you got viral. And in that case, you really don't need to see a GP or anybody for that, because it's most likely step-limited. But the moment you have fevers and OHL, then you basically your first starting point is your GP. Your GP should not give you antibiotics really against use of antibiotic in this country, because most of them really been abused and it's not necessary. And I think we should just stay out of antibiotic usage in this country, and should be indicated, and it should be more sensitivity directed actually. And also probably a color speeder or radiological image should confirm that. So I think that's where the problem comes in. So I think cough per se, we should not be very worried about treating cough. I think we must start more probably concerned about the underlying, and I mean, you see,
Where it comes from. Yeah.
Dr. Engelberg just coughed. Maybe we should give antibiotic.
I think the problem comes in with that cough more than 8 weeks.
Yes.
That's usually where the problem comes in. And some of these viruses, like influenza, you can cough up to 3 months. And it doesn't matter what you do, the patients are going to cough in eventually. But the one thing while you were talking, I remember you had this one case about the specialist aspiration. Is it a patient that aspirated something in the lung?
Yes, sir.
That was a child? Or
Was a child, well, yeah. And yeah, so
I think you have to investigate this more than 8 weeks. That is where patients will come and see
very
you.
important.
Patients will come and see you between 3 to 8 weeks, but those ones after 8 weeks, those are the ones that become problematic.
But also, I think, as I mentioned, acute cough, of course, you have to look also at red flags. Now, if someone cough for 1 day, does not mean that you can ignore them. If they got blood sputum, of course, you worry. If they have fever and protein sputum, means there's pneumonia. You kind of have to look at all those. And again, if they have underlying conditions, means there's a problem. So maybe they should just need to see, is there a person underlying problem or not? And is this cough been recurrent? Because some people tell you, I come to a doctor because I've been coughing for the last 1 year. Every 3 weeks I get sick, or 3 months, then you know that probably got underlying immune problem. So it's not really, I think for me, it's to heighten awareness that the cough can be serious, but also at the same time, people can have a knee-jerk response, which is very unnecessary.
And cough does not equal
to
lung.
not equal to lungs, yeah.
Yeah. If anybody online or anybody else got a question? Let's see someone.
Anybody there?
Great.
It's Annette. Thank you.
Okay.